And then these are meant to be glasses because we're going to take a myopic view of the elbow and take a look at which tissues we think are going to be the best targets for our isometric approaches, particularly at the tendon. So many muscles are multiple inside and outside, so we need to selectively choose because we may find that some tissues are more of a lower hanging fruit. Obviously, we expect there to be redundancy for all of the things at the extensor or the flexor mass, but we're going to pick the ones that are the most provocative. We'll talk about that as we move on through the different sections of this video. But then lastly, nutrition, supplementation, blood work, and sleep. So maybe we'll try to finish part one here as we describe that. Clearly, when we are looking to create new tissue, it doesn't come from nothing. So basing on the assumption that, or at least the understanding that everything in the body is made out of protein. I've got other YouTubes and Instagrams that talk about this. So how much you eat is going to be very significant. And if we are eating for an injury and trying to support this recovery process, even more protein is going to be ideal. And we simply just say endeavor towards that amount. This is, and of course, this is assuming that this is a healthy, non-diseased individual. Supplementation to support connective tissue is clearly part of where we're talking, but then other types of supplementation to get you into an anabolic state. Just we think of anabolics, and it's a very scary word, but ultimately to achieve anabolic state is when you're looking to grow tissue, and we are looking to grow tissue. We are going to do something to create a new inflammatory response. That's where PRP fits. That's where our therapy fits. But then we need remodeling. And that remodeling is going to be fueled by protein. So if you're not eating enough protein, then it's going to start to pull from other areas. And I think we had that video where we used the ski slope as an example of where protein will be prioritized from your organs. If you're training and trying to build tissue, muscle tissue through other methods, these are all the end game of creating this anabolic environment. And that anabolic environment is, during training, is really turning on the signal of a big vacuum cleaner or a big magnet. But the vacuum cleaner sucks in these areas when you sleep. So if somebody comes to me and is saying, all right, man, you're the guy I want to do, this is again, the purpose of videos like this is really what we do. I'm not giving direct advice. We're always going to build this out. But on day one, if someone's telling me I'll do what I need to do, finances are not an issue, or I've tried everything. Well, maybe you didn't try everything because nobody even just talked about this. These are things that have to be a part of the process, or it's just not going to work. And clearly, to be able to best decide supplementation, even certain types of nutritional things, as well as how we take advantage of sleep, blood work needs to be a part of that. So we should not be afraid of creating anabolic. Lifting heavy weights is a critical component to creating that anabolic environment, and we're going to do that with other areas of his body, so we don't provoke this elbow, but he's got 2 legs, a trunk, another arm, and if we can create proper protocols, lifting heavy makes connective tissue grow more, and that's a very important piece that we should be able to consider. So to recap, that's really where we're at, and then we'll start to look at in part 2, and then we'll see if we can even get to a part 3 of okay, this is what we saw, and then maybe part 3 is what we'll do, coming back to these pieces of how do we just start to pack up the train, even if the train hasn't left the station. So let's take a look at those things in part 2. All right, after significant discussion, then we go into our SFMA, same way we would try to do it for just about everybody, particularly when the issue's chronic. Obviously, SFMA isn't going to help us when somebody's crawling in with back pain, but there's still the concepts that will still be able to be very useful. Now, as we know, I use smiley faces because I don't typically even favor terms like DP, DN, etc., but I think they're very, very useful to everybody talking the same language. That is the language I would use to communicate to another professional. It is not the language that I use to communicate to my patient. They're allowed to know if something's desirable, undesirable, and that's why we use the faces. I do not want to use words like dysfunctional or painful to a patient who's already confused with their current environment. Okay, so touch your toes, no problem. Bend backwards with arms overhead, the right shoulder, put the right shoulder down, no pain. So right off the bat, we are able to get some level of confirmation that the shoulder is something. It remains to be seen what that something is and how or if it impacts overloading these tendons at the elbow, but I know shoulder is an issue. Rotation, all sorts of changes as we deload one side. And typically, if you deload the same side and rotate to the same side, that is internal rotation on the ipsilateral rotating side, and it's external rotation. So when we broke this down, we found, that the right hip internal rotation is better than the left. Okay, so we took it aside. I said, all right, so now what we're seeing here, nothing in your hip has anything to do with the acute symptoms of your elbow. However, I do have some questions in how you swing the golf club. As a right-handed golfer, your issues are in the backswing, I said to him. And he's like, yeah, that's exactly. And then I said, I'm not the guy. I get you to that point, and then we're going to go work with someone else at some point, because if we get the elbow into a great place and you're happy, but then you go back to golf and you continue to throw that overload back in, at best, nothing happens. At best, we just don't get any worse. So understanding hip rotation here was very, very significant. That was the big piece that came out of that. Thoracic rotation, not great, but it was at least symmetrical. Single leg stance, he wasn't bad, but nothing delivered there. Deep squat, like most people, not being able to get down. His ankle mobility was interesting, because I don't give the instructions to keep your knee straight. He ran his knee into his other side in the standing closed chain dorsiflexion test. So maybe we'll put that on another video. So I think his dorsiflexion will probably clean up pretty quickly. So I don't know where that doesn't necessarily fit into his extension or his rotation. Medial rotation extension, position 1, aptly scratch, reaching behind your waist, up your back, painful on the right side and not very good on the left. Same thing with lateral rotation flexion, except no pain. So that's why he gets a normal, a medium face versus a sad face. Cervical extension, that was the worst of it. Cervical rotation, also significantly limited. So when we put this all together, as we do local biomechanical assessment where we have pain, our shoulder remember, I think something that's very, very important to appreciate when we talk about the SFMA is like, well, there's nothing for the elbow. False. You don't know how to do the SFMA correctly if that's what you think, because you are not dismissing other methods and other concepts and principles that have been proven to be brilliantly successful. So what would be a certain concept? Well, one would be you will always look above and below the painful joint. So the SFMA took you to a painful shoulder in multiple situations. Okay, one of which was flexion, the other one was extension. So I got some serious questions about what's going on here on that right shoulder, particularly as it relates to overloading your elbow in a complex athletic movement. That being said, I'm going to look above and below. We had no radiating symptoms from the neck. We tested all of that. Well, that's not the SFMA. Of course it is. It's just not part of this concept. You're kind of taking all the puzzle pieces and dumping them out. And then as you start to build out one corner of the puzzle, you might have to shake up the pieces again to turn over the other ones to find everything that you need for that part of the puzzle. So clearly, looking at trigger points of the rotator cuff, we did not exhaust that here on day 1, but that's going to be on our list. And we definitely need to improve motion, both pain-free and total motion, not rotation, but overall degrees of freedom through both shoulders as it relates to supporting what we're going to try to accomplish at the elbow. Okay, so now going back to where our approach here, when we look at, we build out our plan, then what are we going to do? We are going to do exercises and therapy that are going to support the isometrics. So by improving what we see at the shoulder, by improving what we see at the neck, at a more comprehensive level for tennis and golf, what are we going to do over at the hips? Those are our targets, so that we can bring up those ingredients to the recipe, so that when we really focus on what we do at the elbow for our isometric piece, that's where other things can support that from a pain relief. Because really what we have to be after is bouts of 30 seconds, maximal hold, with probably a 3 or under a 3 or a 4 out of 10 pain. And we're going to do 4 rounds of that with 2 minutes of rest in between. And that is the protocol that I think is going to be best matched, because we do have this resection of the flexor mass. So because there's this gap, we're going to treat that as if the tendon is basically has a hole in it. This is very, very common that you'll see in the patellar tendon. You put them in a leg extension machine and crank it back into as much stretch as you possibly can. You know the quads are slack because you have hip flexion, and then you'll primarily be affecting the tendon with maximal isometrics. That is within under a 4 out of 10. But you can do therapy, you can do needles, we can use kinesio tape, which we did upon leaving, and it was a significant value for him. None of those things are going to last. It's almost like a PRP. Like if you only do those things and you only do manual therapy and you feel perfect when you leave and then it just comes back, it's not so much that that was a bad therapy, it's just not going to last. It's not going to do anything to the actual tissue that we're going to use that isometric protocol. 30 seconds on, 2 minutes off, 4 rounds. And then there's an entire piece that we did not get to that can support the from a supplementation standpoint, that can support the collagen growth using that protocol. That if it's exciting information, Keith Barr, very prolific on YouTube, but also just overall a very, very keen message to all of these types of things. And this is, I prefer to subscribe to his messages simply because he's primarily a strength coach. He's not a rah-rah, get physical therapy, loading. To me, that's ridiculous stuff I was talking about in 2009, but you'd rather listen to, some decrepit old lady who thinks you should leg press heavy. Of course you should leg press heavy, but those people that listen to her wouldn't even know who Keith Barr was. So I think that's very, very useful to have those types of protocols where they're very, very defined, but everything is also included in terms of nutrition and then training the rest of your body. That's crucial. And then here, what are we going to do as a 180-pound man? I said just endeavor, to get to 180 grams of protein, and just endeavor for 100 ounces of water. I don't know that 100 is going to be our landing point. I don't know that 180, in fact, as I mentioned, we would typically go above that for supporting injured processes. So that's how we map this out. Now, the 3 positions that we did go in this 30 seconds on, 2 minutes off was wrist flexion with ulnar deviation. Okay, so we did needle that muscle, and then we went into that. Strength increased significantly by needling the muscle. That does cast a little aspersion on what percentage of this problem really is tendon based, because his strength was significantly improved, almost to perfect. But I can't leave that on the table. So we showed him how to rig the rubber band, because with all of his shoulder instability and mobility restrictions, being on his back limits the demands of this sagittal stabilization in a more vertical position. We're going to get there, but we're not going to start there. So he's going to be doing wrist flexion with ulnar deviation. He's also going to work on pronation, and he's also going to work on, which actually turned out to be the least impacted for pain, which was brachioradialis. So we were looking at forearm neutral flexion. That one was the most painful. So we treated all 3 of those areas and then went into the isometrics. And then when we put the tape on, all of a sudden, the radial deviation, and we put the tape medially, but the lateral side had less symptoms. So I don't know exactly where all these landing points are, but this was how we unraveled this. In this case, because I had a gap, I did see him longer than an hour. I did value the conversation that we had, because here's somebody that had a long time just confused, probably seeing some slappy individuals that just weren't getting it done for him. And I think it was important that if I'm going to be the guy to help him, it has to be a very, very tepid and a very, very measured type of conversation, because just to come out and say, oh, you were just going to McDonald's, why would you even think you'd be better? I'm pretty sure that's not going to make any friends or have a repeat customer. So to talk about things and basically start over and be like, because at the end of the day, I have to take the assumptions that everything you were doing was great, and it was just not in a complete program. All the therapy rehab was great. It was just that maybe the humoral and hormonal profile wasn't supporting connective tissue. Maybe the manual therapy was great, but you weren't doing anything specifically to change this connective tissue. Maybe everything was great, but your swing is so ridiculous that it keeps loading up this chicken wing and creates this very, very inefficient pattern on that medial side of your elbow. I'm going to make all those assumptions so that I don't have to be negative, even though in this case, I do think this individual was probably seeing some goofy folks. So that's how we'll put this all together. We'll make videos showing those different isometrics. We'll make videos perhaps talking about the thoracic drills that we're going to do. We're going to talk about how we'll get after that cervical neck. Lots of things that we're going to get after here, and we'll turn it into a little bit of a storyboard over the next couple weeks as we film, and maybe even just show you maybe needle, but I won't take the needle out of the tube. I'll just make believe we'll fake it, because I don't think it's a good idea for people to be messing with needles. I also don't think it's a very, very good idea to go anywhere near the Crichton section of Mobile, Alabama, and not look up in that tree, because you might see that leprechaun.